Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
The three major hospitals in Memphis are fighting coronavirus. Tonight on Behind the Headlines. I'm Eric Barnes with the Daily Memphian. Thanks for joining us as we continue to do the show remotely. I am pleased to be joined tonight by the three CEOs of the major healthcare hospital systems in Memphis. I'll start with Jason Little, CEO, Baptist Memorial Healthcare. Thanks for joining us.
Thank you for having me.
Reginald Coopwood is the CEO of Regional One. Thank you for joining us.
Absolutely.
And Michael Uwicki is CEO of Methodist Le Bonheur Healthcare. Thank you for joining us.
Thank you, Eric.
There is so much to talk about, and I appreciate immensely the three of you making time in this sort of crazy, busy situation to talk with us. I think there's so many places to start as well, but I want to start with the ICU capacity. I think that's a number that a lot of healthcare professionals look at. It's a more case rates can go up and down depending on how much testing is being done. There's some variability there, but the ICU capacity is a finite number. And maybe I'll start with Dr. Uwicki. What happens? We're at about 90% full right now as of Thursday morning when we tape this. We've been inching upward. What happens if we hit 100%? What next?
Thank you, Eric, again, for having three of us here today. We are obviously committed to making sure that we're taking care of patients in this community. So we've been watching the volume increase in COVID over the last several weeks. As most of us know, the number has been inching, like you stated earlier, and we're getting to that critical capacity. So our goal, obviously, is to make sure that we surge up within our facilities. We do have our average capacity, and we also have a surge plan, which allows us to use places that are traditionally not ICU rooms to surge up in order to accommodate additional volumes as they come. So we are all prepared. We have a set of plans that we've developed collectively that will be executed when that time comes.
Are you, Jason Little, I'll switch to you. I mean, are you all assuming at this point you are going to break that 100% and have to, go into your surge plans?
Yes. I mean, I think we're already working on all of those contingencies actively right now. Like Michael said, whether that's adding rooms and adding staff by, converting heretofore not negative pressure rooms to negative pressure, or, looking at other hospitals that we have in our systems where we can transfer patients, focusing on discharge capabilities, moving patients who are ready to be discharged out of the facilities and into nursing homes. All of the various levers that we have at our disposal to pull, we are already, about the process of pulling them actively.
And Dr. Coopwood, and again, each of you has different hospitals, but I know there's a tremendous amount of coordination and communication going on between you three. But to bring you in, Dr. Coopwood, are you? Well, one, I don't know who can answer this, but I'll go with you, Dr. Coopwood. When does the kind of emergency overflow hospital in the old commercial appeal building, at what point would that get activated? And the second question is, how are you doing in terms of supplies, PPE, and just the materials and stuff in a technical term that you need to deal with this rise in ICU cases, Dr. Coopwood?
Well, one of the things you have people in the community who are COVID positive don't need to be in the hospital. You have those who are in the hospital who are too sick to be home, but not sick enough to be in the ICU. And then you have the ICU. What you really want are those that are in the hospital to get better and go back home. But what we see is those that are in the hospital continue to get worse and then are transferred up into the ICU. We too have a surge capacity. We serve the community for trauma and burn and high risk OB, and so it's a complicating factor. in trying to make sure that we maintain adequate space for the emergencies that happen in this community while we also take care of those COVID patients. Where the opening of the alternate care hospital, we haven't really been clear on what that trigger is. I know they would have a significant staffing need, but it's those patients who are between those who come to the ED that may not need to be admitted, that would take up a regular bed, would be those I think that would be more suitable for that space, to divert them to the alternate care hospital while we take care of those people who need a little more aggressive care.
And I want to stick with you. You brought up a good point that you all are, what is it, level 4 or level 5? I can't remember the level of trauma, but the highest level trauma care in the area.
Level 1.
Level 1. Sorry, I did it backwards. Like I said, level 1. And that how does that work? I mean, where you've got to keep a certain number of beds open for, I mean, people are still driving and sadly getting into car wrecks, and there are still fires, and there's still the kind of most traumatic care that ends up with you in your hospital in many situations. Are you at a point where you have to not take COVID patients because you've got to keep a certain amount of space open for these other emergencies? And I know you all have that, but Regional 1 has a particular role in that.
So, I mean, our role, as any hospital's role, if they show up on our campus in our emergency rooms, we have to take care of them. So, COVID positive patients that come, by car, by family, we receive them in our emergency room. We treat them and admit them if they have to. We try to limit the amount of ambulance traffic into our medical ambulance traffic into our facility when we get to this 90, 95, and like we had during the 4th of July weekend, we exceeded 100% capacity a couple times. So we don't turn anyone away, but we do try to manage the medical urgencies and emergencies, and Baptist and Methodist and St. Francis take probably a bigger share of those, while we try to leave capacity for trauma. You just don't want to put us out of business. And then it's not that Baptist and Methodist can't handle trauma; it's not what they specialize in. So it's in the best interest of this community that we have the doctors on call, we have the operating rooms open and ready to run. And that's the best place for those car accidents or any kind of injuries. Right.
Let me switch back to Dr. Uwicki, and for all of you, but I'll just start with you. As this increase in cases, obviously the positive rate has gone up, the case rate has gone up, but again, the ICU capacity is inching upward. That surge plan you referenced, do you have the materials you need, everything from masks to face masks, all the things really that we saw go haywire, and so sadly haywire in New York City some couple months ago, in Italy some months ago? I mean, are we gonna be able to avoid that?
Yes, Eric, a good question. We are definitely in a better position now than we were at the beginning of this pandemic, as you referenced earlier. Yes, we have enough supplies of PPEs on hand, ventilators as well, and the supply chain has significantly improved since the start of the pandemic. So we're confident that we'll have all the materials that we need to surge.
Jason Little at Baptist, the testing turnaround nationally, there's stories that testing turnaround has slowed down as more and more people are going to get testing. I got tested a couple of months ago, and it was, I think, a 24-hour turnaround. I have friends and others who've been tested recently here in Memphis. It's been a very quick turnaround. Do you see that staying as a quick 24-hour turnaround, or are you worried that the testing turnaround is going to slow down as it has elsewhere?
No, we're worried, and it has slowed down, Eric. That was going to be what I added on to what Dr. Uwicki said. I think we're in a much better position from a PPE standpoint than we were months ago. But the one major issue that's out there now are reagents for doing testing. There's a couple of major platforms that testing is happening on around the country. And it's one of those issues where, Michael and Reginald and I love things that are, that are in our control. But when it comes to doing tests, we can draw the specimen from the patient, but then we send it off to a commercial lab, and then they get the reagents from manufacturers to process those tests. And so the reagents, there was an issue last week in the manufacturing of one of those major reagents that the labs use. And so that really is the bottleneck right now. Yes, we've had it's taken longer to get testing here locally, but it's now taking longer to get your results back. And what we hope that doesn't translate into are fewer people interested in getting testing. It's still a very important element in the fight against coronavirus to know whether or not you're positive and then to quarantine. And so, we're actively working on things like pooled testing, other platforms, other labs that we can use across the community. And this is something that Dr. Coopwood and Mike and I talk about a lot.
Talk a little bit about what pool testing is. Well, first of all, am I right in saying a reagent is a chemical at a base level, just so people follow that? Some of the chemicals in the process, this is Eric speak here, but
yes,
right.
Correct. That makes the lab signal whether or not it was a positive test or not. Correct.
Gotcha. And the pool testing is not, I don't mean to be flippant, is not swimming pool testing. We did a story on it, but it's an interesting concept. Can you talk a little bit about more what pool testing means? Yeah,
I'd be glad to. I mean, what it really does is it increases the number of people who can be tested quickly, and it brings the cost of testing down. So in the asymptomatic population, there's very, very low still positivity rates. And so one of the ways that we can test more asymptomatic people is instead of just putting one person's nasal swab in a vial, we could put 7 people's nasal swab in a vial, run that one test. The probability would show that it would be negative. You do nothing further. But if you did that 100 different times, you may have 2 vials that then have positive virus, and you go back to each one of those groups of 7, those 14 people in this case, and then do an individual test to determine who has it. So it's just a way of much faster testing and much more cost-effective testing, particularly in the asymptomatic population, those who don't have symptoms.
Let me go again. I'm kind of going around here, and I want to preface this that I'm not trying to be political when I bring this up, but unfortunately, when you talk about the CDC right now and some of the federal responses, some people take it politically, and I don't mean that this way, but this week, and I'll go to Dr. Coopwood on this, you drew the short straw, the CDC and the Department of Health and Human Services at the federal level, sometime in the last few days, said that HHS was going to take over the collection of data nationally from the CDC. There's been some questions about that, some concerns. Do you have any, do you all supply your data right now to CDC, or do you give it to the health department, which then gives it to the CDC? And what do you think about this switch?
So we give it to health department or the state health department. We have a HERT system that reports bed availability, positivity rates, and all of that. So we report into that. I don't know how it was getting to the CDC, whether it was from the state database, had an obligation to send it to the CDC. But that's best I know. We weren't directly sending our data to the CDC.
Is that the same with you, Dr. Uwicki and Jason? Is it something where you're not really directly sending data to the CDC, so this doesn't necessarily impact you directly?
That is correct. So all the hospitals in the state are using the same process.
Okay. We'll move on to, where do I go next? I'll stay with you, Dr. Uwicki, and what numbers, we talked a lot about ICU, and some of this gets into media coverage, right? We all, Commercial Appeal, all the media in town, the other TV stations, all trying to cover this on a daily basis. Sometimes we focus maybe on numbers we shouldn't, it's been a learning process for the media, for people looking at whether it's the UTHSC website or the Baptist site or the Shelby County site, like trying to get information. What information do you, Dr. Uwicki, look at every day, every week to lower your blood pressure or that really raises your blood pressure? What are those key numbers that you're watching?
Very good question, Eric. Thank you again. The numbers that we look at, we have a daily dashboard that we've developed since this pandemic started. And we track pretty much all the tests that we're doing, positive, negative numbers coming in. I don't worry so much in terms of number of people testing positive in the community, because the more testing you do, obviously, you're going to get a whole lot of people testing positive for it. What I worry about is the number that actually comes into the hospital to be admitted, particularly those that are on vents and those that are in our ICU beds. Those are the ones that worry me the most. So if I see those numbers creeping up, then it begins to worry me.
Dr. Coopwood, for you, is that a similar answer, or what are you looking at on a daily, weekly basis?
It's pretty much the same for me. I think when the prevalence rises in the community, there's a kind of an expectation from us that we're going to see an increased volume. So if the county numbers start going back down below 100 a day, down to 50 a day, there will be a subsequent drop in amount of admissions, amount of ICU admissions, and amount of those on the ventilator. So there's a correlative. It's not direct. I can't tell you if this percent goes up, we'll see a reduction. There's a correlation between the prevalence in the community and the burden that we will have in our hospitals to take care of those individuals that are sick. I like to see those community numbers go down, because ultimately our numbers will go down and we'll get back to normal rates.
Jason Little, Dr. Cooper just said normal. One thing that has not been normal is elective procedures in all the healthcare systems, and it's been a real problem. And I think in some ways, elective procedures makes it sound like stub toe and maybe some kind of optional procedure. Elective procedures can be very, very serious, right? I mean, it can be everything. I've heard the examples. It can be things causing a great deal of pain and discomfort. It's just simply not life-threatening. It's not so much that it's elective. Where is Baptist right now in terms of offering elective procedures, and where is the public's perception of the safety? Because I know that's been a problem, that people are afraid to go to the hospital because they don't want to catch COVID.
Yeah, thank you. Where Baptist is different by state. We have an order in Mississippi where we have 10 hospitals from the health commissioner there that we're not allowed to do elective cases that require an overnight stay any longer as of last week. Not true in Tennessee. So here, like my colleagues on the show today, we are offering elective cases, but we're having to watch how many surgeries we do in a day to be sure that we are, again, it's one of those levers that we have to watch to be sure that we maintain the ICU capacity for patients that need it.
And so in Tennessee, you are, because there was a stretch of time where you were not allowed to do elective procedures. Am I right about that? Or did you choose?
You are correct. No, we were not allowed to. We were able to start that back up in May, second week of May. And so we've all been working to that end since then.
How much how much of a hassle is it that, again, you just brought up the regional issue? Memphis is kind of the heart of a four state area, certainly 3 states. How difficult is it to manage the different rules across state lines, both where you have hospitals, but also if someone comes across from Arkansas and enters a Baptist hospital for care, emergency care, you're going to help them regardless of where they live. But are there complications that creates?
Well, I think what I want your viewers to know is we're adept at doing that. I mean, moving patients where they can receive the best care, that's what we do on a daily basis. And so when it comes to different rules by market and where hotspots are existing, what we really, I think, all would agree. I know my colleagues would agree with this. Our hospitals are a safe place to receive care. What we don't want to happen are for people to be so concerned about coronavirus that they're not coming into the emergency room for chest pain or for stroke-like symptoms. Our hospitals, frankly, have very, very low incidence of coronavirus and very high records now for the last several months of using PPE effectively to keep our team members, our employees safe. and our patients. And we'll continue to do that. Looking at surgeries, you are required at Baptist to get tested for coronavirus before you come in for that elective procedure. And we'll continue all of those policies and continue to deliver care in the right way. But I really would want everybody to understand you don't need to delay coming and getting important health care that can be life-threatening out of fear of coronavirus. We're ready to receive you, and we're working together, Dr. Cooperwood and Dr. Uwicki and myself and others, to be sure that we coordinate that for our community.
Go to you, Dr. Uwicki, with a very tough question that you may not even had time to sort of process, but because everything is so fast and changing so much. But we're 3-4 months into this. The last time I saw you, we were at the Memphis TEDx event. I introduced you, and at that time, coronavirus was something that was happening very, very far away. And I think we talked about it for a second. We weren't there to talk about coronavirus. This was probably mid-February. As you look back over the last 3-4 months in Memphis, are there things that Memphis should have done differently? Are there things that we need to learn from that? Or is it too soon to have that conversation?
Eric, again, during that conversation, we talked about it. It was a distant pandemic coming, but no one knew that it would be to this degree. Obviously, we can all sit back and do a Monday morning quarterback and guess what we could have, should have. I think if we had taken it very serious from national level all the way to the state level and maybe to the county level, maybe we could have done some things differently. Even now, I think we still have an opportunity, quite frankly. We can still begin to follow the data, follow all the recommendations coming in to begin to decrease this epidemic. So it's not too late, but again, the longer we go without obviously wearing masks and, social distancing and washing our hands and, doing all this stuff that has been recommended, the more we will continue to see this. So, we can't change what has happened over the last 3 months, but going forward, we have an opportunity to make a difference.
I'm going to switch gears just a little bit. I'll go to Dr. Cooper on this. The three of you have coordinated tremendously on this whole response, on the medical response and the healthcare response to COVID-19. But in early June, when George Floyd was killed in Minneapolis, which then sort of has started this national conversation and a national outcry about race and equality, you all wrote an op-ed, the three of you, which you were nice enough to send to us at the Daily Memphian. And I think it opened, in the middle of the pandemic, we are so painfully reminded of another problem. Racism is as insidious as it is intractable. No simple vaccine will save us from it. Dr. Cooperwood, how did that come about? And why did you all feel you needed to, as hospital executives, address racism so publicly and so in such a unified way?
Well, it's the George Floyd incident, brought all this to the forefront. Conversations were happening in all sectors of the community and of the country. And we had not, as individually, we were having conversations within our facilities. And Michael brought the idea to us to say, is there a way that we can have a concerted effort so that there's no opportunity for the public to say, well, Baptist said something, Regional 1 didn't, Methodist didn't. And so we all looked at and made recommendations to the op-ed. And it was something that we all felt that we could be comfortable about because systemic racism and unfair treatment in some areas of minorities is a real issue in communities, and a community such as Memphis that has a high percentage of African Americans. We felt we needed to make a statement that we, as leaders of the largest healthcare systems, feel this is something that we needed to address together.
And I'll go to you, Jason. I mean, you all are on the front lines. You made the point in the op-ed. Black Americans, Black people in Memphis, they have shorter life expectancies. The infant mortality rate is much higher. I mean, you've lived this as long as you've been in hospitals, I assume.
Absolutely. I mean, they're really conversations born out of larger discussions about racism that really live inside the healthcare industry that we need to own. And I think that was really the point of collaborating. There are disparities inside our own communities that affect people's access to healthcare. And, those are things that we can address and should address and, are all actively working to do.
Dr. Wiki, just a minute, 45 seconds left. Your thoughts on looking at the racial inequality. I mean, in some ways, in my lifetime, it would be impossible to sit and do this interview and have two Black men head up, such major institutions in an American city. So in some ways, we've made this tremendous progress, but obviously we have not made nearly enough.
Yes, thank you again, Eric. Yes, we are blessed, obviously, to have the community that we have. But besides that, we still have social injustice in our community as well as every other part of this country. And I think some of them are systemic, and we need to, as organizations such as ourselves and others, to truly begin to dismantle every form of racism, put from our policies directly or indirectly, and being able to take a proactive stance on some of these issues. As my colleagues mentioned, the issues of social determinants of health, which are the main causes of the disparities in care, has been with us for quite some time. And we can't dissolve or resolve that without changing some of the issues that are causing that. Food insecurity, housing, jobs, and those kinds of things. Some we can do, others we need the greater community to be part of it.
All right. Well, that is all we have. We have time on that, but I definitely want to touch on the issue. Thank you all for what you're doing. Thank you for joining us, and thank you for watching. Join us again next week. Remember, you can get past episodes of Behind the Headlines on the WKNO website, or you can download the podcast on the Daily Memphian site or wherever you get your podcasts. See you next week.